Trying to see if the chat works on screen. There we go. Okay. Sounds okay? Did it freeze? Okay. Well, ask any questions you got. Mic is low. Okay, hang on. Okay, Raymond, did you still have that question about Brown Sequard? Okay. So Brown Sequard, remember, it is a hemisection of the spinal cord. So basically, you're going to lose all of these functions on the side of the injury. Trying to see if everything comes up right. So, there we go. So again, looking at the level, we lose all of this on that one side. It's not going to work anymore. So anything coming in at the level of the injury, depending on what sensation you're having, you may have problems on the left, you may have problems on the right. So let's let me erase some things here, make it easier. And on this Brown Sequard, guys, don't go crazy figuring out all the different problems. Just remember, basically, I would remember just this one is the biggest one to remember for Brown Sequard. So in this case, we have injury, right? We have left T10. That's where the problem is. So here is your left T10 and it's blocked out. So we know that that is where the injury is. Along the dermatome of T10, and no matter where it goes, they are going to have loss of all sensations at the level of T10 and anything in that dermatome. Again, this could be T10, it could be L5, it doesn't matter. Whatever level you're talking about, they're always going to present the same way. At the level of the injury, on the side of the injury, they're going to lose all sensations. Pain and temperature, light touch and pressure, vibratory sense, position sense, proprioception, all will be lost. And at the level, they're going to have a lower motor neuron lesion. So they're going to have those symptoms. These are all lower motor neuron diseases. Below the lesion, okay? On the contralateral side, okay, so the opposite side of the injury, pain and temperature are lost. Light touch and pressure. That's going to be on the contralateral side, because remember, these all have to cross over and go up. T10 is injured. You can't get past it. All that's lost. Ipsilateral changes. The same side of the lesion. Here's your proprioception, vibratory 2-point discrimination, joint position sense, all those things that follow the dorsal white column go all the way up. But where does the dorsal white column cross over? It doesn't cross over into the medulla. So you lose all that stuff. They can't get up. because you have a T10 is damaged, those signals cannot get through. So on the ipsilateral, the same side, you lose proprioception. Now, and all the position sense and vibratory sense, all that stuff. Now, because the upper motor neuron, and remember, I'll put it in green, the upper motor neuron starts all the way up there in the precentral gyrus. This one nerve, well, I'll put it on the right because it crosses over. Okay, we start here. The same nerve comes over, crosses over, and goes down all the way. The problem is, as soon as it hits the site of injury, it stops. So the upper motor neuron in this case is damaged, signal can't get down, so along that ipsilateral side, they're going to have upper motor neuron lesions because the upper motor neuron is not really working. It can't get past T10. So on the ipsilateral side of the lesion, you will also have upper motor neuron lesions. Okay, so Kaylee asked, I know this is a CMS class. They are going to be a lot of patho in this case because the treatments are very, very simple for the most part. No, especially for like a lot of those symptoms that we went over, the diseases that have more of symptom management, make sure you understand those things. A lot of them is spasticity. With spasticity, a lot of them you give, baclofen and so forth. So this first unit is a lot of phys, pathophys. The second unit, we're going to go through a lot more treatment because those have a lot more treatments. Because Brown-Séquard, again, you basically just give steroids and then you just need neurosurgery to repair the spine or stabilize it at least. So again, just because of the stuff that we did in this section, there's not going to be a lot of treatments right now. What else? So again, spinal cord compression, they need to see oncology to reduce the size of the tumor and neurosurgery to remove it. So there's not much there to do as far as treatments. We're going to get to that a lot more in the next unit when we talk about strokes, seizures. There's a lot more medications for that one. Okay, myasthenia gravis. I'll just put up the slides. Nope, it's a mess. Okay. So myasthenia gravis. The key thing with myasthenia gravis is right here. Let me just erase all my stuff here. Okay. Myasthenia gravis. Remember, it's an antibody that attacks the receptors. So it's going to stop the receptor from working as well as it should. Think of it just like insulin resistance with diabetes. The target tissue is no longer responsive to insulin. And just like with myasthenia gravis, the acetylcholine receptors are no longer responsive to acetylcholine. Therefore, you have no transmission of the signal to the next, either part of the muscle in this case. Now, Lambert's sign, let me erase all my stuff on this one. So Lambert's sign is increased power with muscle contraction. Every time you go to squeeze, it gets better. And why does it get better? Because more acetylcholine has been dumped into that synaptic cleft. So what we're doing is we're overloading acetylcholine so that it can have a greater effect at the postsynaptic membrane, because a lot of those receptors have been obliterated due to myasthenia gravis, so they're not working. So that's what Lambert's sign is, that the strength gets better on repeated squeezes on the hand grip strength. So there's another form, which is Lambert-Eaton, where it stops. It's up there. It kind of got cut out. But what it does is it stops the release of acetylcholine. That's what Lambert-Eaton is, another one, but Lambert's sign is that it gets better. The key thing, okay, so here we are with our tensilon test. We give them edrophonium. Edrophonium is acetylcholine receptor. Oh, I'm sorry, that's not that one. There's acetylcholinesterase. I put ACE. Let me just rewrite that. Okay, so the ACE, the inhibitor of acetylcholine that breaks down acetylcholine in the synaptic cleft. The tensilon test, what it does is it prevents the breakdown of acetylcholine in that synaptic cleft, so more of the acetylcholine sits around longer and longer and longer, thereby giving a better strength on the next successive squeeze because there's more acetylcholine in the synaptic cleft, so you get a better squeeze on the hand grip strength. So again, it improves because we're giving an acetylcholinesterase inhibitor, which is going to prevent the breakdown of acetylcholine, so it sticks around and you get a better response. So if they do have that, then we know it's a good sign that they have myasthenia gravis, and we can give them neostigmine is the big one, and again, they're just going to help with the acetylcholine. Other examples, remember, this is the big one as well, the thymectomy with myasthenia gravis patients. But I hope, Hannah, that answered your question regarding Lambert's sign, which is improved grip strength with repeated squeezes. But Lambert-Eaton syndrome is a different one where it prevents acetylcholine release from the presynaptic. Any more questions, anyone? Or do you want me to go over? Okay, so brown sequard again. Pull that up. Okay. At the site, and let me just add another page. Okay. So we have our spinal cord. We have, so remember we have our anterior gray horn. When we have at the site of the lesion, remember we have our upper motor neuron. I'll put it over here. Well, no, it doesn't do that. Okay. So remember, the synapse occurs, I don't know if I'm drawing it right, but anyway. There's our upper and there's our lower. So when you destroy this whole side, this synapse is obliterated, and the lower motor neuron is obliterated as well. So that's why at the site of the lesion, they have a lower motor neuron disease, or symptoms of lower motor neuron lesion. Because at the level, at the T10, or wherever the injury is, this whole synapse is destroyed. The lower motor neuron is destroyed. It's not going to work anymore. So you have a lower motor neuron at that point. Now, the reason you get let's go below the injury. Here we are. So below the injury, these neurons are coming down. This is the upper motor neuron, right? Comes from the brain all the way down, follows its cortical spinal tract, and it goes all the way down in every single vertebrae. It's going to leave to go down its spinal nerve to be and innervate whatever muscles it's got to go to. However, because we obliterated T10, that upper motor neuron gets cut, and everything below it loses the upper motor neuron. So the upper motor neuron will never hit T11, T12, L1. So it's an upper motor neuron damage below the injury because you lost the upper motor neuron. The connection's gone. It's been severed. So you lose it, and that's it. So I hope that answered your question regarding the lower motor neuron. Question about peripheral and central vertigo. Okay. The biggest table for that one that I want you to know this is one of the big ones to know regarding for peripheral and central vertigo. So make sure you really understand this one. So latent period, when you put them down, how fast do they start getting? Is there a latent period? Do they immediately go to nystagmus, or is there a delay? If they immediately go to nystagmus, there's no delay. It is central disorder. We know it's anything with the brain. If there's a lag period, 2 to 20 seconds before you start seeing the nystagmus, we know it's a peripheral problem. The duration, if it's short-lived and it goes away within a minute, again, peripheral. If the nystagmus, the bouncing or rotary, whatever's going on, lasts more than a minute, then you have a central disorder. Fatigability. Every time you put them down for the Dix Hall Pike, every time you do that, if it's a peripheral disorder, they're going to eventually stop having the nystagmus. It's going to fatigue out. But if it's a central problem, there's no fatiguing of the nystagmus. The direction of the nystagmus, usually going to be rotary, so it's going to bounce like that, like ours. And the central may change position. But here's the other key thing, the intensity of the vertigo. In a peripheral disorder, benign paroxysmal positional vertigo, Meniere's disease, they're going to, once you put them down, they're going to have severe nausea. They're not going to feel good. They're going to want it to stop. In a central disorder, the symptoms are very mild, if any at all. And where is... Okay, so these are the only ones that are peripheral disorders. BPPV, Meniere's disease, acoustic neuroma. Just if I mention anything about facial numbness or weakness, we know the facial nerve goes along the same tract as the vestibulocochlear nerve. So if you have an acoustic neuroma around the sheath, it gets bigger from the tumor that's there, and it compresses the facial nerve. It's a very easy one for that one. Medication, ototoxicity, again, they're going to be on, usually it's one of those aminoglycosides. You give them an antibiotic, and they come back a week later, like, oh, I'm having trouble hearing now. It's the medication that caused that issue. And then the central ones, okay, alcohol intoxication, okay, it's a central problem because where's the problem happening? It's in the cerebellum. Alcohol is toxic to the cerebellum, so therefore it's a central problem. Wernicke's encephalopathy, same thing. Wernicke's area, temporal area of the brain. Loss of thiamine is the big one with this one. So there's one of your treatments you gotta know. Thiamine. Multiple sclerosis. It's a demyelinating disease of what? The central nervous system. So it's a central disorder. Alcoholic cerebellar degeneration, we talked about that. Again, alcohol is toxic to the cerebellum, and chronic alcoholics, that cerebellum gets smaller. It's not going to regrow. They're going to get issues. Your TIA strokes and cerebellar ataxias. Again, these are all central issues that can cause vertigo. So Hannah asked, from the Kahoot, if a patient loses a vibratory sense in the left hand, why is the lesion in the spinal cord and not in the medulla? It depends where the lesion is. And I don't remember what the question was for that one. Let me see what else we got here. So Hannah, let me know what that question was, where the lesion is, and we'll go over that one. And remember also, Hannah, any vibratory sense, if it's below the crossover, any injury is going to be ipsilateral. So just remember, with vibratory sense, position sense, discriminative touch, majority of the time it's going to be ipsilateral to the lesion itself. Quick answer for this one, Gabby, when you use caloric testing versus Dix-Hallpike, caloric testing is a brain reflex. So that is really going to be used a lot when you're trying to determine, again, are the pathways working? So remember with that one, let me bring it up here. Okay. Vestibular ocular pathways are pretty much what you're looking for. Whereas Dix-Hallpike, you know they already have dizziness or vertigo, and you're trying to reproduce it and see which way they go from there. If the neural pathways are intact, they're going to have vertigo and nystagmus. So that's very important to know. If you put the water in the ear and the eyes start bouncing around and everything, that means your nerves are intact and everything's all good. Again, normal patient, you're going to have nystagmus within 30 seconds. If a patient has unilateral vestibular dysfunction, irrigation of the affected side fails to cause nystagmus. So you put everything in the right ear, you don't see any bouncing going on, the right ear has the issue. That is where the lesion is. Okay, I'll pull the Kahoot up in a second. And again, unconscious patient, if brainstem reflexes are intact, the eyes will deviate towards to the irrigated ear. So it's another one of those brain reflexes. You can put stuff in and see how it goes to the brain and comes back down and see which way it goes. Okay, let me pull up the Kahoot here. Okay, so Hannah, that question 13, that's a bad question to begin with, but no, again, vibratory sense is going to be the same side, so it's always going to be left, or well, whatever the lesion side is. Because it crossovers in the medulla, same thing with motor, they don't really get affected, the whole contralateral thing, unless they have a stroke. And we'll get to strokes tomorrow, I think. So that's the issue with that one was but I would, in the exam, I will exactly tell you where the lesion is, what level it is. But again, the vibratory sense, proprioception, going up that dorsal white column is always going to be in the medulla as the crossover, same as motor. But remember, pain and temperature, light touch and pressure crossover at the level of the spinal cord. So really keep those things aligned up so you don't confuse them. But the whole contralateral side is really when it happens, the lesion is above the crossover. So strokes, if you have a right-sided stroke, your left side is going to be down, and so forth. Okay, Yadi, the upper motor and lower motor neuron diseases. And lesions. Okay, lower motor neuron. 1, flaccid paralysis. If the lower motor neuron's not working, nothing is telling the muscle what to do. Right? Nothing is telling the muscle what to do, so you have immediate flaccid paralysis. There's going to be no tone there. Nothing is telling it what to do. Areflexia or hyporeflexia. Remember on those, the reflex arcs, it goes sensory right into the spinal cord, and it's going to bounce to the lower motor neuron to go to the muscle so that you have your reflex. But your lower motor neuron is damaged, so that reflex arc is gone. It doesn't work anymore. So that's why you have areflexia or hyperreflexia. Fasciculations. Think of, you have a really, really bad wire that's charging your phone. The insulation's been ripped off. You have to hold the wire in a certain way or it charges or it shuts off. That's a lower motor neuron problem. Remember the example of the outlet. The power from the breaker box going to the back of the outlet switch is your upper motor neuron. The outlet itself is the synapse. When you plug in a cord, you are plugging in the lower motor neuron. And when you do that with a bad wire, sometimes it charges, sometimes it doesn't. You get fasciculations. Sometimes it goes through, sometimes it doesn't. That's fasciculations. Weakness, decreased tone. Again, the lower motor neuron is not stimulating. The neuromuscular junction doesn't work because the nerve doesn't do anything. So you get weakness, decreased tone, atrophy because you're not using that muscle anymore. It's going to go away. So that's where the atrophy comes in. So that's all lower motor neuron issues. Upper motor neuron problems. Spastic paralysis. If the upper motor neuron going into the outlet is not working very well, no matter what you plug in, sometimes it'll work, sometimes it won't. Hyperreflexia. The lower motor neuron is still going, it still works. So when you do your reflex testing, your DTRs, it's going to have hyperreflexia because the lower motor neuron is finally being stimulated. It's going to go crazy. Increased tone with the upper motor neuron, and your Babinski's, again, goes to the brain. So just remember what these are. You don't have to know exactly why they cause each one, but just remember these are lower motor neuron diseases or lesion symptoms, and these are the upper motor neuron symptoms as well. Just checking all the questions here, make sure I got them all. Okay, I think I got them all. See if anything else here we gotta worry about. Remember, ALS is an upper and lower motor neuron. Let me just clear this page. Both upper and lower. Why is it both upper and lower? We're obliterating the lateral cortical spinal tract. this is the upper motor neuron because this travels all the way down, right? This is all one nerve coming from the brain. We obliterated that, so our upper motor neuron doesn't work. What also are we obliterating? Anterior gray horn. What happens in the anterior gray horn? The synapse between the upper and the lower motor neurons. And if you obliterate the anterior gray horn, there can be no synapse, so the lower motor neuron now has nothing to do. So you get both upper and lower. Here's the other important thing with ALS, no sensory, cognitive, or ocular motor defects, so the eyes are okay. Sensory is okay. Obviously, the intellect and cognition are fine. Again, just think of Stephen Hawking with regards to ALS. Again, treatment, you can give riluzole, but what's the most important thing for the ALS patients? Management of your symptoms. So again, as you're going through, yeah, there really is no treatment for ALS, but it's symptom management. So a question may say, what is the type of medicine that you would want to give to a patient with ALS? And I explain any of those things. Obviously, it's going to be, look at, what do you need to do for your patient long term? How do you make them as comfortable as possible? What else in here? MS, remember, demyelination of white matter, obviously only in the CNS. Asymmetric, remember, wherever these lesions show up, space and time, every time you get a new lesion, it's a new symptom they're going to have, a new flare-up. More females than males, again, mid-30s, remember your ages for these things. Blurred vision is one of the big ones they're going to have. Fatigue, loss of position sense, so they have problems when they walk. What else? Dawson's figure, make sure you remember those things. Okay, dosages, folate, you got to know the dosage for that. Everything else, you don't need a dosage. When we get to the strokes and we get to seizures, then we'll start getting into a little more dosaging with regards to the anti-seizure meds. And H&P lecture, diagnostic tools. Know, obviously, within the diagnostic testing for neuro, know what they have. Like what's the purpose? Definitely lumbar punctures. Make sure you know all of the purpose of doing it, the composition of the CSF fluid. What else? H&P, go over, a lot of it should be a lot of review. You guys have done a lot of, history taking and learning about them throughout your time here so far. We just did it from a neuro perspective, but again, when I said the ones that have the signs you don't miss, the must not miss ones, there it is. This is a big one. Make sure you remember this one. We've gone through bladder and bowel many times. Again, worst headache of my life, sudden blindness, worst pain is worse at night. Under those, saying like those things are very important. So if you see them anywhere, make sure you understand. Like, okay, that's something that clue me, and that may be something more serious that's going on. And let me pull up that first one. Slide 94. Okay. This is actually the same thing I went over in that other slide, but it's all the same stuff. So bulk. Again, these are upper motor neuron. Let me put it here. Lesions and lesions. So you're having damage. So bulk, what's going to happen to the muscles? The muscle in an upper motor neuron lesion is going to stay normal because a lower motor neuron is still intact. So it's going to be normal until you just stop using it and then you lose atrophy. In a lower motor neuron, because now the lower motor neuron is definitely damaged and cut, essentially, or swollen, or whatever you want to call it, it's just not working. Prominent weakness, that flaccid paralysis. Okay, that lower motor neuron is not working, it's not binding to anything, that muscle is not going to work, and it goes away. The tone, what's the tone of your muscles like? In an upper motor neuron, they're going to have increased tone. That lower motor neuron is going to kind of stay like irritated and going to keep that muscle, the tone increase a little bit. Except, again, in spinal shock, we're going to have some recovery period. Tone of the muscle, hypotonia, always with lower motor neuron because there's no nerve touching the muscle. That muscle will never work again. Over time it may, but normally it won't. So they're going to have hypotonia. They're going to be very, very loose muscle, no tone there. If you touch their arm, it's squishy. Both muscles don't work. Power. How much power can they generate with their muscles? Upper motor neuron is going to be reduced. Again, the upper motor neuron is not really speaking very well to the lower one to tell it what to do. So they can have reduced power. But in a lower motor neuron, severely decreased because that lower motor neuron is not attached anymore. It's not going to tell the muscle what to do. So you lose all your power in that muscle. Abnormal movements, fasciculations, you'll see with a lower motor neuron lesion. Reflexes, again, hyperreflexia and hyporeflexia. That lower motor neuron is gone. There's no reflex arc to happen with the DTRs, so reflexes go away. Your Babinski reflex upgoing with a lower motor neuron. Remember, these are brain reflexes, so that upper motor neuron has to send a signal back down to the toes to what it's going to do. Because the upper motor neuron is damaged, they're going to have upgoing toes and downgoing toes for the lower motor neuron. Okay. Hopefully that answers your questions, Gabby and Hannah. See what else was important. Yeah, we'll do a lot more next unit. This was just our introductory stuff. Polio, lower motor neurons. You need to know, Callie, the contents. Just make sure you understand that, glucose should be low. Protein should be low. Understand what things will show up in the CSF with certain diseases. So make sure, especially with MS. Oligoclonal bands, make sure you understand that. That's going to be high in MS. Also, your myelin protein is going to be high. Glucose is going to be normal. There's no bacteria to eat up all the glucose, so it stays normal. Emma, you should have known that in PD1 over last summer, so you should know that already. I hope so. For DTRs and strength, that should all have been PD1. don't think I have the diagnostic testing one here. Let me add it real fast. And I'll pull up the, here we go. Make sure you understand the contraindications for some of these things too, especially lumbar punctures. The big ones, anyone with papilledema, don't do a lumbar puncture on them. If you think they have a brain abscess, elevated intracranial pressure, which would give you the papilledema, don't do lumbar punctures. So make sure you know this one. You don't need to know the actual numbers, but again, should be clear. No white blood cells. Just use common sense. Just think, there's no infection. Why would I have white blood cells? If I have white blood cells up, infection. What are they trying to fight off? This one, you don't need to know the percentage, but understand that if glucose starts going down, it's because we are eating glucose, and what eats glucose? Bacteria. Protein should be low. Lactate level we just order. And obviously the antigen testing is all just stuff we do with the tubes. Make sure you understand this one too. Which order, the most important thing obviously is glucose, protein, and lactate. And then obviously after that, we do our gram stains and whatnot. We want to know if this is bacterial or viral. We'll get to meningitis next unit, and we'll talk about viral versus bacterial and why it's so important. Okay, brown sequard again. You will get brown sequard again in ortho, so don't worry about it so much right now. Just understand what it is. Okay, so at the level of the lesion is the next question. At the level. At the level, okay, so this is our left, here's our right. Injury, that T10. At the level of the injury, we lose everything because nothing can cross into it, nothing can go up. So just think about all the synapses in that one half of the spinal cord have been obliterated, they're not going to work. Everything coming up, once it hits that lesion, that level of the spinal cord, everything stops. So they lose all sensations just at the level. Now, if I said they had a brown sequard at L4, go back to your dermatomes and know the path of L4. Think about like sciatic pain. Sciatica is like L4, L5, and it travels all the way down that dermatome. So make sure you know all the dermatomes and what muscles are innervated. That was a question I asked you guys on the Kahoot. If they lost flexion of the wrist, but they still have extension, where's the problem? So they lose all sensation. Now, with regards to lower motor neuron lesion at the level of the injury, because there is our precentral gyrus. This motor neuron crosses over at the medulla, comes all the way down and gets to here. Now, this upper motor neuron is here. It's not bilaterally, just on the side. Don't worry about anything with crossovers, Jared. Just memorize this slide. That's all you got to know. Everything I did before was trying to explain it, how it works. But if you want to just memorize this one slide, this is perfectly fine to memorize this one slide. But the loss of sensation is just on the side of the lesion. That's it. The other side's okay. So we lose everything in a lower. So the upper motor neuron in red, it comes all the way down. But the lower motor neuron that's going to try and get out gets blocked because the synapse is destroyed. The upper motor neuron is okay to get down there, but at the level, because we destroyed the anterior gray horn as well, the synapse can't occur, therefore you lose all your lower motor neuron functions, and that's what happens. And there's your lower motor neuron lesion symptoms. Below the injury, The lower motor neuron is okay. The problem is the upper motor neuron can't get past T10. So because T10 blocked it, it cut that upper motor neuron. It can't get through. Everything below is going to exhibit an upper motor neuron lesion because the upper motor neuron can't get through T10 and it's stuck. And then just remember pain and temperature, light, touch, and pressure as well. And then here's all your other things that you lose on that side. So just memorize this one. Bring it back, I'm gonna put a fan on. What else with testing? So make sure you understand the blood distribution for all three of those, what levels they are at. PET scans, remember they're functional. MRA is looking at vasculature, make sure there's no stenosis anywhere. Aneurysms, make sure nothing's going on. Spine x-rays, muscle, carotids for TIAs, and your biopsies. Remember all this stuff when you're going through, especially for PD, and you start learning about neuro later on. Again, think about it as just a brain problem, cord, nerve, neuromuscular junction, or muscle. Friedreich's ataxia. The big thing with Friedreich's that I want you to know, debilitating, okay. Okay. Genetic, remember that. Posterior columns. So what's in your posterior columns? Vibratory sense, proprioception, discriminative touch. They lose that. Lateral corticospinal tracts. Is that muscle or is that sensory? Muscle. And peripheral nerve issues. Spinal cord becomes thin, myelin sheath destroyed, and everything kind of pulls away from all the muscles. Again, gait ataxia first. Sensory loss comes later. That's really it. Don't go crazy with this one. And those are tumors. Okay. So question is, if we have an upper motor neuron unable to send signals past the level of injury and bounds required, why don't they have a lower motor neuron? Because the lower motor neuron is still intact. It's still gonna, like if you do a reflex, it still may do something. Let me go back. Where's the slide? That's over here. have, because the lower motor neuron is still there, it still works. Upper motor neuron just can't tell it what to do. But DTRs, decreased, again, nothing with a lower motor neuron, but with an upper hyperreflexia, so the reflexes still work because the lower motor neuron is still intact. So like DTRs will still work because that lower motor neuron is still there. It's just hyperreflexic with an upper motor neuron, but they're still going to have them there. So don't worry so much about the why with Brown-Séquard. Just remember what happens. That's the best thing I can tell you. Brown-Séquard is very tricky to understand, but just understand that one table. That one slide, where is it? This one. Just remember this one, memorize this one, that's all you gotta do. I won't give you anything tricky and say they have a stroke. I'll tell you exactly what level it's gonna be along the vertebrae and let me know what's going on. So don't stress out about Brown-Séquard. Just understand the level it's at, what happens below, and this is all right here. And that as well. One straightforward. Hernias are straightforward. Just remember, cauda equina just in the central. Normally, other ones are off to the side, and whatever side they're on, they're going to pinch. We went through ALS. No carpal tunnel, the test that you would do. Example of being above the crossover besides a stroke. Brain abscess causing compression on one side of the brain versus the other. Anything dealing with the structure of the brain can cause those issues, Hannah. What else? Make sure you remember this one. Type 1 doesn't have peripheral nerve injury. Type 2 does have nerve injury. Again, treatment, PTOT, again, there's nothing much there from meds, but make sure you know it's NSAIDs, your TCAs. Make sure you remember also when it's nerve pain, neuropathic pain, you have to give these, or gabapentin, because those are nerve pain drugs to help with nerve pain. They're not going to do much when it comes to normal muscle pain. When you take like an Advil or ibuprofen, when you have nerve pain, you got to give them one of those things that are stronger. Okay, let's go over neurotransmitters. So the neurotransmitters should be a brief review from before. Okay, so you don't have to know so much the diseases, but just understand which ones are the stimulatory ones, which ones are inhibitory. Which ones are more found in the brain, which one more found in the periphery. Um, Again, primary neurotransmitter of the peripheral nervous system is your acetylcholine. Obviously, we know cholinergic receptors, not the adrenergic. Those are sympathetic. Skeletal muscles, usually excitatory. You don't need to know those things. I would know that. Anticholinergic syndrome. So kind of remember what the symptoms are. Remember glutamate, stimulatory. We'll go through all these a lot more when we get to the different diseases next unit. But again, glutamate we know is stimulatory. So remember that. Dopamine. Inhibitor neurotransmitter produces arousal. Again, dopamine is a neurotransmitter that obviously is our reward pathway. So you'll see it when you get into a lot more of the excuse me, the behavioral health stuff. Reward pathways, addiction. Okay, all it's trying to do is just get a dopamine kick, so they feel better. Substantia nigra, make sure you remember that. The damage to substantia nigra we'll go through when we get more to like Parkinson's in the next unit. But again, just remember, not enough dopamine, too much inhibition of spontaneous movement. And that's why they get that cogwheel rigidity, because they can't do a nice smooth function because the dopamine isn't there anymore. Too much inhibition, so we get stuck along the way. It's that cogwheel rigidity. Serotonin. We went through that already. So MAOs. So remember, we give a drug MAOI, and that's yours to get more serotonin to sit in the receptors longer, in the synaptic cleft longer, so it sticks around longer, so it has more of an effect. Make sure you remember what serotonin does, all those fun things. We'll get to this when we get to headaches, and we'll go over what serotonin does. Remember, serotonin causes dilation of the blood vessels. I'm sorry, decreased serotonin. Not enough serotonin causes dilation, and it's the dilation that causes you to have headaches. Your vessels get bigger. That's why caffeine works. Anxiety, impulsive behavior. GABA, again, inhibitory. So remember, GABA is the inhibitory neurotransmitter of the brain. Again, we'll talk about a lot of this stuff next unit when we get to GABA. Again, remember the main things about GABA. Inhibitory of the brain, and substantia nigra is a lot of it found there. Norepinephrine, sympathetic neurotransmitter. We know what by now, thanks to Dr. Wood, you know all the receptors, and that's blood-brain barrier as well. So those are the 5 neurotransmitters, kind of have an idea of what they do. We'll get to, obviously, the receptors a lot more next unit, because a lot of the drugs that we're going to talk about attack that NMDA receptor. And actually, they make it easy for us, because the drug that does that is called Namenda, NMDA. So make it easy to remember. Anything else in this one? Remember these ones, these other causes of issues: vitamin B12 deficiency, myelin formation, diabetes. That's at type 3 diabetes. We didn't really talk about that much, but it's type 3. Can cause Alzheimer's disease. And obviously alcoholism has a big problem with the cerebellum. And that was that one. And then lastly, on this lecture, remember the diencephalon, what does that go into is a big one. And then the all the M's basically are your medulla. So just remember that way. I'm not going to go into great detail about this, but the diencephalon we do mention a lot by itself as the diencephalon by itself. So that we talk about whenever you hear diencephalon, we're talking about the thalamus and the hypothalamus. Same thing there. Make sure you know all the neural crest, what the crest differentiates into, all the PNS, and the tube is all your CNS. So make sure you remember those things. Here's your spina bifida. Make sure you remember your folic acid, the different cells, and what they do. Again, should be repeat parts of the brain. So make sure you remember. Basically remember, where is it? This one. Parietal lobe is your sensory, your frontal lobe, motor, personality, problem solving. Temporal lobe is language, hearing, and speech. Remember comprehension, so Wernicke's effects there. Occipital lobe is your vision. Cerebellum, balance, coordination of movements. Your brainstem is obviously all your vital functions. That's why I mentioned before that if you have a brainstem infarct and you can't control your vital signs, your breathing, your body just can't do it anymore, that's a very, very bad prognosis because that means you have a brainstem infarct. And other important things is blood supply. So make sure you guys remember. We did all that already. Let's go the fast way. These ones. Posterior, middle, and anterior. Make sure you remember this one, and this is the really big one that explains why. This is your anterior supply. Here's your middle supply, and there's your posterior supply. So a lot of the problems, especially AFib, goes usually to the middle cerebral artery. So a lot of times people with AFib will come in face drooping. Here's the face. Tongue. We'll talk about with strokes. When you guys do your cranial nerve 12, you have them stick their tongue out. You're going to see deviations in their tongue if they've had a stroke. That's one of the things we look for. So make sure you know blood supply. Again, sensory can be affected just as much as the other one can. And we just know that it's the same body parts that are there. Venous flow, just remember that's there. Protection, make sure you know these things. Scalp and dura, arachnoid and pia. This is an error, make sure you know this one. Where the bloods are, between what layers and what are they called. Here's your CSF stuff. And then what's the other stuff you've already gone through? Let's see with this one, anything more in here. So remember, gentamicin is the big one that causes a lot of these ototoxicity issues. They're all aminoglycosides, but gentamicin is the worst one. Here's your acoustic neuroma again. Again, treatment is just surgery. There's nothing else you want to do for that. It's surgery. There's no medicine, so nothing really to worry about. Your question before about the treatments. Again, any dizziness, they're always going to have meclizine and scopolamine. No matter what the dizziness is, just give them that medicine because it helps with their symptoms. With Meniere's disease, remember, the endolymph is the problem. So you want anything we can do to lower the volume of the endolymph. So by reducing your salt, reduce the volume. You can give diuretics, which will help reduce the volume as well. The big thing with Meniere's disease is this oral pressure. Remember I said before, it's AU. Okay, so you're gonna have pressure on the ear. It's gonna feel full, usually one-sided. Some people do have bilateral Meniere's, but for the most part, it's gonna be one-sided. So that oral pressure is a big key with diagnosing Meniere's disease. Again, BPPV is just meclizine and scopolamine. Just remember those two. Again, just remember, this is an very good one here, talking about peripheral lesions and disorders. Again, outside the brain, sudden onset of vertigo, can last for a while. Intense vertigo symptoms, the central ones didn't really have that. When you move your head down in different areas, they didn't have intense symptoms, but remember the video we watched that one old lady did who had peripheral disease. And as soon as she went down, she's like, I don't feel good because the symptoms come on real fast. Intermittent only usually happens when they turn their head real fast. So again, always ask your patient what was going on before. Significant distress because they do have a lot of symptoms. No neurological findings on exam. So once they don't have those symptoms anymore and the vertigo goes away, they're back to normal like nothing's ever wrong. Central within the brain itself, they're going to have ataxia. So that is a neuro finding. Problems with that. Vertigo they had before and also an nystagmus. Slowly over several months, little to no changes with head movement. And they may have other focal neurological signs as well. So that's the big thing to remember with central versus peripheral, those disorders. So you never go into know also. Okay, onset, when does it happen? We went through that already with this big slide. Where is it? Central versus peripheral and when they start. Here it is. This one. So this is a go into know also. I think you'll have a lot more questions in the next unit just because it has a lot more diseases and conditions that we spend a lot of time in the beginning just going over all the basic stuff with neurology. We'll get to a lot more stuff next unit. I'll also give you guys a lecture. Some of you know already, but I mean, whoever's here is here. On one of the days where we have a short lecture, I'm going to give it's optional, people can stick around if they want, but I'll give a lecture about medical marijuana and how that works because a lot of the conditions that will give you the card are all neuro related. So we'll talk about that and the different types and how they help with different neural conditions. So we'll do that next semester. Oh, next unit, not semester. Next unit. Let's see if there's anything else that's important. No, make sure you really understand the types of peripheral neuropathy. Okay, so Sana, so obviously I got here now, so we'll answer that question. Ascending versus descending paralysis. So in GBS, it's an ascending paralysis. So it's going to start in your feet, and then it's going to work its way up the lower leg. It's an ascending paralysis. They're going to lose it in their toes first, and then it's going to go to the foot, and then the calf, and then on its way up. So it's an ascending paralysis. It's also symmetrical. So they're going to have it on both feet, and it's going to get worse and worse and worse going all the way up. So that is Guillain-Barré. So make sure you know that Guillain-Barré is a symmetrical ascending paralysis. With Botox, go to Botox here. Okay. So remember, home canned food, that was in the Kahoot. They were eating a lot of canned tuna. This is a descending paralysis. So it's going to happen usually starts in the proximal area and it works its way down. So it's a descending paralysis. So that's why you got to know that one. The other key one, I don't think I have it on this one, is the diabetic peripheral neuropathy. And this is a stocking glove. So it's feet and hands. That's where it starts. That's what, with peripheral neuropathies, what you're going to see with their numbness and tingling. It's going to be the hands and the feet. So all the distal limbs and whatnot. So that's the diabetic one. So those are the big three things you got to know. Guillain-Barré is an ascending paralysis, Botox is a descending paralysis, and diabetic peripheral neuropathy is a stocking glove type of paresthesia, feet and the hands. And those are the big ones as far as the different types of paresthesias. Obviously with Guillain-Barré and Botox, it's a muscular problem. Peripheral neuropathy is a sensory problem. But again, make sure you understand which one is which. So this one's a really good one to know also. Again, here's your Botox, and that prevents the release of acetylcholine at the presynaptic side. You remember myasthenia gravis is a post-synaptic side. Your aminoglycosides are also a presynaptic. The Lambert-Eaton actually blocks the sodium. Lambert-Eaton syndrome. It blocks the calcium channel, so if calcium doesn't get released into the presynaptic vesicle, There's no exocytosis, neurotransmitter can't be released. So they're all neuromuscular junction problems. Lambert sign is the fact that with repeated muscle contraction, it gets better. That's what Lambert sign is. But they're all neuromuscular junction problems. Tetanus, remember about tetanus, contaminated wounds. Blocks GABA with tetanus. Okay, so we have unchecked excitatory impulses. Nothing is inhibiting it to calm it down so you can relax. So you have constant contraction. GABA is gone, nothing is telling it to relax. Here's your diabetic neuropathy. All the different symptoms they have. Tight glucose control is always treatment number one for peripheral neuropathy. You always want to rule out other causes of peripheral neuropathy that can be easily treated. Obviously, with diabetes, it's a different story. But if they have these issues, you just treat those other ways. Here's your stocking glove distribution. So hand numbness and sensory loss may develop later. The Lambert sign will also work for both, but we just talked about Lambert sign as far as the squeezing, repetitive squeezing. But make sure you just understand what myasthenia gravis is. As it's a postsynaptic issue, and Lambert sign just says that as I squeeze more, I get better. Herpes zoster, just the big thing with this one, the dermatome pattern. And you got to give them neuropathic pain relievers. Okay, that post-herpetic neuralgia is very, very painful. Make sure you treat that. Here's your polio. We went through that already. CRPS, MS. There's Dawson plaques, you'll see. The Dawson lesions and everything you'll see with MS. That's only for MS. Multifocal peripheral neuropathies. Obviously, there's going to be different parts of the whole body. So it's not just one nerve that got pinched, like carpal tunnel. You have multiple. So whenever you have multiple peripheral neuropathies, multifocal, there's got to be some sort of systemic problem going on that causes the whole, all the nerves to go damaged. Because when you just have simple nerve like carpal tunnel, it's just one nerve that's causing the problem. But with either due to impingement of the tract that it comes out of, impingement of the neck, something's going on to pinch one nerve. But when you have a lot of different nerves, like diabetes, we talk about stocking gloves, obviously your hands and your feet had to be affected. Something is going on. And these are some examples of systemic things that can cause issues. So noxious stimuli. Let's go to, here we go. We want to know their level of consciousness. So we want to know how deep into a coma they can possibly be. Why is this not updating here? Okay, my thing's not updated. Just shut it off. It'll come back up in a second. Okay. Let me just fix this. Okay. Okay. painful stimuli. So the different types of noxious stimuli, rubbing their sternum with your knuckles and like really digging in there, taking a pen and putting it on your nail bed and squeezing, those are noxious stimuli. You want to see, are they going to respond to that pain? If someone is stuporous, they're still going to kind of move around a little bit if you hurt them. Okay, they still perceive pain. If they're in a coma, they don't perceive pain anymore. There's no sensory input going on. They don't get pain, therefore nothing to arouse them. Those are the big key things with noxious stimuli. And that's why you do it. You just want to see what their level of consciousness is. If someone is like you come in to see a patient and they are sleeping, let's say, you shake them, they wake up, they're just lethargic and they just fall back asleep. Obtunded, they're going to be a little bit confused. Where am I? What am I doing here? Difficult to arouse. But when you get to the last two, you have to differentiate what their brain activity is like. So by doing these painful stimuli, you want to see, do they wake up or not? If they don't, they're in a coma. If they do arouse with painful stimuli, then it's considered stuporous. So make sure you know these different levels of consciousness, because we're going to get to this next unit when we talk about disorders of consciousness, talking about delirium versus dementia. And we're going to have to differentiate between delirium and dementia, and some of these things are there as well. So this is another going to know as well. The different diagnoses or the definitions, what the condition is, the description of what it means, and where the problem is. Again, this has to do with lobes, knowing the function of the lobes, what they're responsible for, and then you can figure out where the lesion is and what the problem is. So this is a going. And remember, non-dominant, the dominant lobe, handwriting. What hand do they use to write? I am right-handed, so my left side of my brain is my dominant hemisphere. So if you have a patient coming in who doesn't recognize objects in those hands, and remember, they may have it only on one side. Like we put it in the right hand, I don't feel anything. My left hand, I do, whatever. Work backwards, figure out what hand they write with. Okay, this is their dominant hemisphere, but they're having issues on the non-dominant. So that kind of tells you with agnosia, the problem is going to be in their non-dominant hemisphere. And must not miss, make sure you remember those. Kind of remember your physical diagnosis stuff, what all the cranial nerves, what they do. Neuro stuff. This ROS doesn't really change, obviously, but they're all the same. Social history. Again, what they do for work. Okay, that'll tell you a lot with different metabolic disorders. Again, Alice in Wonderland, the Mad Hatter with all the mercury or lead, I think it was, for making hats back in the day. It makes the lead poisoning makes them mad. That's why they're mad as a hatter, because of the metabolic poisoning from the materials that they use during work. Okay, any last questions? We got about 4 or 5 minutes left, so I just want to make sure we get all your questions answered. I think we pretty much reviewed everything too. Oh, I know. Wanted to. It's not great on this one, but make sure you guys also remember it's better in your PowerPoints. I don't know why. I got to figure out the problem. Don't worry about anything with the circle of Willis. Just know it's communicating from left and right sides. We'll get to more vessel stuff when it comes to strokes next week, or tomorrow actually. L4, foot inversion, patellar tendon. Okay, we got an example of a question like this on the Kahoot. Here's your L5, extensor digitorum longus, so they can't hold it up. So they have foot drop. It's not updating again. So make sure you go through those, so you know the innervations and what they're doing. Okay, well, you guys are all set. You guys will do well tomorrow. And I'll see you all first thing in the morning for the exam. Then we have class at 10. So have a good night, everyone, and I will see you all tomorrow.